A 10-day-old newborn is brought to the emergency department 1 hour after seizure. 1 hour after seizure that sorry. A 10-day-old newborn is brought to the emergency department 1 hour after seizure that was involved clonic jerking of the left arm. Clonic jerking of the left arm. He has he had been well until 2 days ago when he began sleeping somewhat more but continued to feed well. Pregnancy, labor, and delivery were uncomplicated. Vital signs are within normal limit. He is difficult. He is difficult to awaken but moves all his extremities when stimulated. He is hypotonic but hyperreflexic. He is hypotonic but hyperreflexic. Babinski sign is present. During the examination, there is a clonic seizure of the right lower extremity. A CT scan shows no abnormalities. CSF glucose 55, protein 110, leukocyte count 85, and erythrocyte count 860. A gram stain is negative. Which of the following is the most likely diagnosis? Ready?
Okay. Neonatal herpes, herpes
Sorry.
encephalitis. Can you hear me?
Now,
Okay. Is neonatal herpes encephalitis. Most likely diagnosis is 10 in 10-day-old infant with new onset seizure, normal head CT and CSF showing increased protein, leukocyte count, normal glucose, consistent, which is consistent with aseptic meningitis. Further suggestive is the presence of red blood cells in the CSF, which is seen in herpetic encephalitis. Most cases of HSV are caused by HSV2, although infection with HSV1 occurs and is treated the same way. Most patients acquire the virus via transmission from mother, often during the third trimester, with encephalitis developing within 1 week. Symptoms are non-specific, include fever, lethargy, poor feeding, occasional seizures, and focal neurologic deficit. Concomitant oral lesions may occur, but their absence does not rule out diagnosis. CSF findings include increased protein, lymphocytes, and normal glucose. In many instances, the virus can be identified in PCR of the CSF, although empiric therapy with IV acyclovir is needed prior to diagnosis. Failure to recognize and treat infection can result in organ dysfunction and death. Long-term sequelae. It's not CMV. Congenital CMV is associated with petechiae, sensory neural hearing loss, jaundice, microcephaly, hepatosplenomegaly, hypotonia. Patient likes these features. Intracranial calcification may be present on CT scan. Okay, next.
a 21-year-old woman comes to the physician because of increasingly frequent headache for past 3 months. The headache are throbbing, occur only on the right side, and are associated with nausea, vomiting, and sensitivity to the light and sound. He has had 1 to 2 headache are yearly since the age of 17 years, but now has 2 or 3 weekly. She is a school teacher and has had no changes in work, lifestyle, or environment. 4 months ago, conjugated estrogen therapy was begun for treatment of menopausal symptoms. Her temperature is 37 degrees Celsius, pulse is 76, respiration 14 per minute, blood pressure 135 by 80. Neurologic examination shows normal. Which of the following is the most appropriate next step in the management?
Ready?
Yes.
This discontinuation of conjugated estrogen therapy. Migraine is a common condition that presents with recurrent primary headaches. Migraine headaches are typically severe unilateral throbbing associated with nausea, vomiting, photophobia, phenophonia. Pain is usually located behind or adjacent to the eye. Some patients additionally experience aura before or during headache. Migraine triggers include stress, menstruation changes, hormonal concentration, weather changes. Fasting and alcohol sleep may improve migraines. Patients who experience migraine associated with conjugated estrogen therapy may require discontinuation of therapy or reduction in dose. Migraines are postulated to arise from deficient serotonin inhibition of the sending pathways. Acute migraine treatment may include triptans and NSAIDs for patients with disabling or frequent migraines. Prophylactic treatment is recommended and include beta blockers, antidepressants, TCAs, SNRIs, where am I? And anticonvulsants. Yeah. Next.
A 67-year-old man is brought to the physician by his wife because of 1 month history of deafness and ringing in both ears and dizziness and difficulty with balance. He also had an occasional sensation. He also had occasional sensation that room is spinning. He was discharged from the hospital 21 days ago after prolonged treatment for pneumonia, sepsis with intravenous ceftriaxone and gentamicin. He has chronic obstructive pulmonary disease, type 2 diabetes mellitus, and congestive heart failure. He has a history of tuberculosis. Medication include digoxin, metformin, losartan. Um, his pulse is 84 per minute, respiration 20 per minute, blood pressure 140 over 85 millimeter of mercury. Examination shown nystagmus on the lateral gauge. Bilateral examination shown nystagmus on the lateral gauge bilaterally. There is severe loss of hearing bilaterally. Air conduction is greater than bone conduction. Air conduction is greater than bone conduction. Um, Results of Weber are normal. Muscle strength, deep tendon reflex normal. Sensory normal. His gait is broad-based and unable to walk in a tandem. Which of the following is the most likely diagnosis? The gait broad-based. There is
Between A,
sorry.
B, and E. And between A, B, and E.
Yes.
1 month
One
dizziness.
thing like he has pneumonia, like after history of respiratory tract infection, then there is vertigo. That is vestibular neuronitis. But on that vestibular neuronitis, there would not be severe loss of hearing bilateral, isn't it?
Yeah, and the whole thing happened. He's been having for 1 month. The whole thing happened 21 days ago. So he's had the thing before he had the infection.
Yes.
Um, mm,
I think that and for many years to happen, vertigo, oral fullness, sensory neural hearing loss should be present. So it is excluded. It
mm.
is there possibility of CP angle tumor?
Not really. I mean, but
But
there's.
why there is severe loss of hearing bilaterally?
But why would it be bilateral? I mean, I guess, yeah, I guess. Um, it can also be aminoglycoside, but then it's after the, because
Uh,
it says prolonged treatment, but it was after, I guess the one that makes sense is the CP angle tumor. Okay, pick one.
okay, let's see.
So it's aminoglycoside induced toxicity. The word prolonged was the key. Ototoxicity is a frequent adverse effect of aminoglycosides such as gentamicin, which exert bactericidal effects by binding blah blah blah. Aminoglycoside accumulate in the inner ear endolymph peridiff and can cause cochlear ototoxicity and vestibulotoxicity, which is typically irreversible. The risk of ototoxicity associated with varicocele may be as high as 10% in some patient population. While there is the increased risk of toxicity with repeat dosing or high doses of toxicity may occur with even the first dose of aminoglycoside. While aminoglycosides are highly effective against broad range of gram-negative bacteria infections such as E. coli, blah, 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 Proteus, Pseudomonas, Serratia, their use is limited by their significant adverse effect. In addition to toxicity and vestibular toxicity, aminoglycosides also have nephrotoxicity. It's not CP angle tumors such as acoustic neuroma, meningioma, or glioma typically affect the vestibulocochlear nerve and other cranial nerves, trigeminal facial abducens. Patient may present with hearing loss and vertigo. Sensory and motor dysfunction of the face and the scapular muscle are also possible. It's not vestibular neuritis, also known as labyrinthitis, caused by inflammation of the vestibular labyrinth and presents with vertigo and nystagmus over a period of several weeks. Patients typically do not present with hearing loss.
Okay.
Okay.
A 72-year-old woman comes to the physician because of 2-day history of pain in the left thigh. 2-day history of pain in the left thigh and flank and weakness of the left leg. She has a 30-year history of type 2 diabetes mellitus currently controlled by glyburide. Examination show weakness of the left iliopsoas and quadriceps muscle. Deep tendon reflex. Deep tendon reflex of the left quadriceps muscle is decreased. Sensation to pinprick is decreased over the left lateral thigh and the medial calf. Which of the following is the most likely location for this finding?
Between L5 and radicular lateral, left lateral thigh. Mm, between femoral
Iliopsoas and
nerve and
quadriceps. Weakness in the iliopsoas.
between L5 and femoral nerve. L5 and femoral nerve. Ah, forgot the dermatums for the lower extremity. Anyway, ready?
Wait. Medial cuff, lateral thigh, lateral thigh, medial cuff, lateral thigh and medial. Okay, well, fine.
Okay. So it's femoral nerve. Lower extremity. Yeah, I knew it was between those two, but I forgot the L5. What is the distribution for that one? I forgot. Lower extremity neuropathies can be caused by nerve compression, ischemia, inflammation, degeneration, infection, transaction. Diabetic patients may develop spontaneous femoral neuropathy secondary to inflammation and ischemia. The femoral nerve arises from L2, L4 and exits the lumbosacral plexus by passing under the inguinal ligament. Neuropathy of the femoral nerve or its roots presents with unilateral quadriceps and iliopsoas weakness, decreased sensation over the anteromedial thigh and medial calf, and absent patellotendon reflex. Patellotendon reflex. Okay. L5, where was that? H. What was
Quadriceps.
yeah. L5 radiculopathy presents with back pain that radiates down the lateral aspect of the leg and foot,
L5 does not have
associated with
any deep
weakness of foot.
tendon reflex, isn't it?
Don't think so. I don't think so. I don't know.
Like if
It's
we look
associated
at
with
the
weakness.
jerk, L4, 5. Okay, you say I am confusing you.
It's okay. Presents with back pain radiates down the lateral aspect of the leg and foot, associated with weakness of foot dorsiflexion, toe extension, foot eversion, and inversion. Numbness occur over the lateral leg and dorsum of the foot. I mean, we can try to look for the lower extremity dermatomes. Mm, no, I hate to read those things. I guess I'll pick that one. So L1 will be here, L2 will be here, L3, L4 will have the patella, I guess, reflex. Uh, yeah, yeah. So L4 will be here and here, and L5 will be, you can see it, dorsum of the foot, and then if we see from the back, I guess just dorsum of the foot makes sense. Yeah, and then S1 will be, I guess, the back of the foot, mostly the back of the leg, the whole back of the leg. And so yeah, L4 will be the patella reflex, and L2 and L3 will be like up here in the inguinal area. Yeah, I don't know how to remember those one like the upper ones. Yeah, Mm, this one makes a little bit of sense.
Yes.
Okay, this one doesn't even show anything. Okay, oh, there it is. So L1, L2 will be a little bit the lateral side. L3, L4. This one is even more complicated.
L4
But
is
L5,
medially now. L4 is medially.
yeah, L4 it seems like it's more medial. L2 is like lateral but up here. L5 is always, I guess, it's always the dorsum of the foot. You can always see it in the dorsum of the foot and lateral here. So lateral up is L2, lateral down is L5. Medial up is L3 and medial down is L4. And next one, it seems like it's kind of always at the back and the bottom of the foot. Okay, so L1, L2, L2, L3, L4. Let me put it in my own feet. L1, L2, L3,
5, 4,
L4, L5.
3, 4,
Okay,
1, 5.
L2, L3. L4, L5. Okay.
Okay, next.
Okay. Where is it? And it has disappeared. This one.
A 72-year-old a 72-year-old man comes to the physician because of 2-month history of progressive tremor of the left hand. He and his family have noticed that his movements have been more shaky during the period. His movement and more shaky during this period. That he has been walking more slowly during the past year. He has hypertension. Current medication include hydrochloric acid and aspirin. There is no history of serious illness. He does not smoke or drink alcohol. His pulse is 56 per minute. Blood pressure 140 over 90 millimeter of mercury. Examination shows a fine tremor of the hands and the examination of the shows a fine tremor of the hands at rest. The tremor is exacerbated by movement. There is cogwheel rigidity of the upper extremity. His gait is slow and shuffling. His gait is slow and shuffling. Mental status shows no abnormality. Which of the following is the most appropriate initial pharmacotherapy?
Ready?
Yes.
So it's carbidopa, levodopa, dopamine agonists used to treat Parkinson by increasing the amount of dopamine available in the Nagastriatal pathway. Carbidopa are given together in order to increase availability of levodopa to the brain. Levodopa is converted to dopamine by the enzyme dopa decarboxylase. In the peripheral circulation and the brain, dopamine is not able to cross the blood-brain barrier. So any levodopa which is converted to dopamine peripherally is unable to affect change in the basal ganglia. Abidopa indirectly increases dopamine availability in the basal ganglia by inhibiting dopa decarboxylase peripherally. In this way, more levodopa is able to cross the BBB and be converted to dopamine in the brain, where it's then able to act on the negostriatal pathway. Increased dopamine leads to improvement of Parkinson's symptoms, including tremor, rigidity, akinesia, cluster, all of that. It's not piri. It's that primidone, barbiturate are both used in the treatment of essential tremor. This patient rests in tremor is Parkinson. Barbiturate. Okay. Next.
A 52-year-old man comes to the physician because of 2-hour history of diffuse bilateral dull headache. Diffuse bilateral dull headache. He has hypertension. He has poorly compliant with his medication. He is alert but confused. His blood pressure is 240 by 150 millimeter of mercury. Fundoscopy examination shows hemorrhage and exudate. Which of the following is the most likely diagnosis?
Mm.
Sure.
Ready?
Hemorrhage. Oh, yes. Mm,
Okay. Hypertensive encephalopathy. Hypertensive may result from acute or severe increases in blood pressure. It potentially manifests with headache, vomiting, agitation, impairment of status, seizure, and may progress to coma. Visual symptoms may result from cortical dysfunction or from hypertensive retinopathy, including hemorrhage and exudates. Treatment include carefully lowering the BP while avoiding excessive graphics in BP, which can cause endocardial ischemia. In general, a decrease in the mean arterial pressure of 25% within the first hour. Sodium diproposite, potent vasodilator, and is preferred agent because of its short half-life, allowing to be titrated via IV infusion. Snatal cerebral hemorrhage can be idiopathic or secondary to trauma, aneurysm, IV malformation, tumors, hypertension. Patient can present with severe headache that can be associated with vomiting. In a patient with non-compliance antihypertensive medication, hypertensive encephalopathy is most likely. Headache with vomiting, and it's not subarachnoid. What is it? Subarachnoid hemorrhage typically presents with acute onset, acute severe headache, along with neck stiffness, photophobia, positional, possible stupor and coma, retinal hemorrhage, accidents, and headaches with severely increased BP are more. Yeah.
Okay.
Okay.
Okay, can we stop here?
You want? Okay. You want to do biostats or you just want to?